Hi, this is Eric Prystowsky. Welcome to another segment of EP on EP. It's a delight, as always, to have my good friend Hugh Calkins here, professor of medicine at Johns Hopkins. And Hugh, welcome to the show one more time.
It's good to be back, Eric.
Yeah,
Thank you for
it's
the
always
invite.
a pleasure. So this is exciting. My understanding is you've just finished a trial on the use of cryoablation and persistent AFib, and I know it's one of the first trials with certain specifications of it. So why don't you tell us about the trial and a little bit of the background and maybe the entry criteria, then we'll go into the results.
This was an important trial because it was designed for FDA labeling of the cryoballoon for treatment of persistent atrial fibrillation. And as you know, currently none of the ablation technologies that we use day in and day out have that official labeling that they're approved for treatment of persistent AFib. So this trial was set up to obtain that labeling. So it was a single-arm study using objective performance criteria. Based on all the trials that have been done, the FDA is comfortable saying if this, the endpoints were a success rate over 40% you had to meet and a complication rate less than 14%.
Less than 14%?
Yes, using all the different bounds and statistical whatever.
That's a big complication rate.
Those were the benchmarks you had to meet to get across the finish line with a win.
Okay, go ahead. So let me ask you this then. Just in the United States or other parts of the world?
No, it was 25 enrolling centers in Canada, the U.S., and Japan.
Great. So how many people were enrolled in the trial?
So ultimately, there were 145 patients with persistent AFib that completed the trial. There were 165 that actually had the cryoballoon ablation procedure. Some patients couldn't handle all the follow-up, so we ended up with 145 patients, which is what we based the overall results on. And these were patients with persistent AFib of less than 6 months duration. So this was not long-standing persistent of 5 years. It wasn't even persistent AFib lasting a year. It was sort of earlier persistent AFib, if you will. AFib less than, no episode could be more than 6 months, continuous AFib.
So let me ask you a couple other things, because this is always an interesting thing to me, because at least in the beginning, while I've been proven wrong on this, I would have assumed persistent AFib, you might need more than just just isolating the pulmonary veins. I think all of us talked about lots of other things. So what were the left atrial sizes, things like that? Were there any things that you learned in this trial that would tell you which one of the patient groups might have been more successful than the other?
We haven't done those analyses yet. The data just got sort of finalized, but that will be something to look at. I mean, this also excluded patients with huge left atrium were not enrolled in the study.
So you define that? In other words, what was your upper LA size?
The cutoff was 5 centimeters.
5 centimeters. Yeah, that makes sense. So tell us about the data. Tell us about the follow-up.
So anyhow, 145 patients were in the study. They got the cryoballoon procedure. The definition of success was based on the consensus document. No AFib, more than 30 AFib tachycardia or flutter, more than 30 seconds from the 3-month end of the blanking period to a year follow-up. And these patients all had Holter monitors at 6 and 12 months. And then they had a TTM where they had to transmit weekly. And also if they had any symptoms, they had to transmit. So that was sort of the end point. And the bottom line is the procedure was successful. The success rate was 55% at 12 months follow-up. And the complication rate was 0.6%.
0.6? That's remarkably low.
There was only one complication, and that was in a patient who had the cryoballoon procedure. It didn't work. The patient was going to get a redo RF procedure. And during that procedure, the transeptal was misdirected, and the patient had tamponade, which was treated. So that was the only complication in the study. And again, the goalposts were the success rate had to be more than 40%, the complication rate less than 14%, and instead we ended up with a 55% success rate and a 0.6% complication. So my sense is that the FDA is going to receive this information favorably.
I think that's wonderful, and congratulations on the trial. Let me ask you a couple other quick things. Phrenic is always something people worry about. Did you have phrenic, and if not, what did you do? What was mandated in the trial to minimize phrenic nerve problems?
Yeah. So I mean, it was mandated that you pace, you pace the diaphragm during energy delivery in the right superior and the right inferior pulmonary veins, but there were no phrenic nerve paralyses that lasted more than several days. So basically, the incidence was essentially 0.
That sounds great. The other thing is, the listeners are going to know about on drug versus not on drug. So, I mean, all these trials, you know, a lot of times you may be on a drug through the blanking period. But at the point of a year, in the success group, how many were absence of antiarrhythmic drugs?
So 80% were off antiarrhythmic drugs at the end of the study. The definition of success was when you had to have an acute procedure success. You had to isolate all 4 pulmonary veins with a cryoballoon or the touch-up freezer catheter. So that was the first part of the definition.
Okay.
The second was no AFib, ATAC, or A-flutter more than 30 seconds from 3 to 12 months. And the third was you could not have your antiarrhythmic drugs either increased or changed. You couldn't switch from flecainide to Sotalol. That would be a failure.
Right.
And it was encouraged that all patients stop antiarrhythmic drugs at 3 months. At the 3-month follow-up point, 40% were on drugs. By the end of the study, 20% of patients were on drugs. And when you looked at the success rate of those on drugs versus off drugs, there was no difference.
I got you. So, have anybody restudied some of these folks? In other words, I always wonder about how much recur, because even though it's actually wonderful success for a first-time procedure and persistence without drugs, that's really terrific. But there's a lot of people who weren't a success. Too early yet to figure out why in those people, or have any of them been restudied to find out if it's a question of veins not isolated versus an alternative site?
Yeah. I mean, that's the question. What is the ceiling for PV isolation and persistent AFib?
Right.
We know it's important. We know it's the cornerstone. As you pointed out, many people believe, well, you got to do more with persistent AFib, and I think this study has taught us, hold your horses. In more than half of your patients, you don't have to do anything more. And you know, this issue about what's the durability of PV isolation, that's something that we're going to have to sort of collect as time goes by.
Right.
Very few patients ended up getting a repeat procedure. I mean, even if they quote-unquote failed, that doesn't mean they're bad enough to justify a second procedure. They may have had 30 seconds at 6 months follow-up and failed on that basis, but there's no way that patient would end up back in the EP lab.
So, for me as a clinician who sends a lot of these folks to the lab, I don't do them myself anymore, this is really outstanding information, because you can say to a patient now, based on your results, that you have a 50% chance with a 1 procedure to have drug-free success in a year. That's a nice piece of information with minimal complications using, if you follow the techniques of the paper, right? So that's really good information for clinicians.
Well, and this issue about should you do more? I mean, if in 50% of patients or 55% you can get them effectively treated with just PV isolation, why go scarring out the atrium with all these additional lesion sites, which may be proarrhythmic? Fine if the patient needs a second procedure. And I think in this study, less than 10 or 15% of patients by the end of a year had had a second procedure. So the redo rate is extremely low. But if they do come back, and if the pulmonary veins are isolated, well, you may choose to do more, whether it's posterior wall isolation or non-pulmonary vein triggers.
Yeah.
But you can get a lot of the way there just by effectively isolating those veins.
And the other thing is, the criteria that you and I have always disagreed on about this 30-second rule, we'll leave it as a friendly disagreement. I think that I don't personally use it in my clinical practice, although I understand it's okay for trials. Some of these people who are failures may have infrequent minimum AFib technically and not need any more regardless.
No, exactly. And the really the importance of the 30-second definition, it allows trials like this to be performed non-randomized with these objective performance criteria based on the last 10 FDA supervised clinical trials that got all of our paroxysmal catheters approved. So it's very useful if you want to design a non-randomized study. Otherwise, you can use a new endpoint and then you can go randomize the patients, which, as we all know, is a much tougher to enroll.
Hugh, thank you. Great information for the listeners, and congratulations on a wonderful trial.
Yes, it was a great team effort.
Thanks, Hugh.